Hi, everyone. It's Dr. Kostelnik with Rooted Behavioral Education. Today, we have a very interesting and unique interview with Dr. Stefan LaTulip talking about neuropsychology and its role in the treatment of a vestibular patient. So I would love to welcome Dr. Stefan LaTulip. He has a Ph.D. in clinical psychology, and he's currently wrapping up his fellowship in neuropsychology in the Chicago area in private practice. So welcome and thanks for being here.
Absolutely. Thanks for having me. I'm excited to talk about some neuropsych today.
Great. So I imagine many people don't know what neuropsychology is. So if you wouldn't mind maybe giving us an overview of what is neuropsychology.
Sure. So what a neuropsychologist does is take some information and it gets at how the overall brain is functioning, sort of cognitively how we're functioning, psychologically, emotionally how we're functioning. And then it also looks at sort of how an individual is functioning in their daily environment. So it's kind of a bit of a cross between neurology and psychology. I'm a trained psychologist. I'm sure we'll talk about that a little bit later, but it kind of looks at neurological signs, but also psychological functioning as well, and helps with kind of diagnoses of what's going on and treatment planning and recommendations of going forward. If there is a diagnosis or a difficulty that a person has, what things can be done to kind of ameliorate that.
Right. Okay. So talk to us a little bit about, I know in your intro, I mentioned a little bit about this. What
Mhm.
type of training is required to become a neuropsychologist?
Sure. So all neuropsychologists have a doctorate, usually in clinical psychology. And so it can be a PhD or a PsyD. And then to be a neuropsychologist, you usually need to have, well, you do need to have postdoctoral training, at least 2 years. So what will happen is you will get your doctorate after you complete your graduate program, complete a 1-year internship. And then after that, you are a doctor and you will engage in training for 2 years with someone else who is also engaged in that training. So someone who has also been through a 2-year postdoctoral fellowship, supervising you, and obviously doing neuropsychology work over those 2 years. So usually individuals before that postdoc will have done at least some neuropsych work in their doctoral schooling at practicum, or in practicum, it means sort of out your kind of clinical practice that you're doing, clinical practice work that you're doing in your doctoral program. You will do some neuropsych then, and also probably during your internship before you go on this 2-year residency. But once you complete the 2-year residency or fellowship, then you are eligible to be a licensed neuropsychologist.
Great. Okay. So let's talk about this from the patient's perspective. So if I'm a
Mm-hmm.
vestibular patient coming in for a neuropsychological evaluation, what can I expect? What is that evaluation going to look like?
Sure. So what usually happens is neuropsychologists do a little bit different. So I'll talk about the model that we kind of do where I'm currently at, but it's all of them are the same. It just depends on when things are being done. If it's over an entire day, if it's split up across multiple days. But what
Okay.
will usually happen is that an individual will come in for an hour, 45 minutes to an hour interview, possibly longer. The client will come in and we will discuss sort of what's bringing us in for testing. So what cognitive symptoms we're noticing. If you're a vestibular patient, when are we having vertigo? When is this occurring? When did this start? Emotional functioning, sleep, medical history. I mean, if you can think of anything that will get at the background information of an individual, we'll try to cover it during that initial interview. Some places will have like a questionnaire that you fill out, so it can make it a little bit easier because that speeds the interview up if the psychologist, neuropsychologist can kind of read something and check off boxes, and we don't have to ask all the questions. We can just kind of refer to the questionnaire. And then once we complete that 45-minute to an hour interview, it can be longer if the case is more complex, then we do testing. So this testing consists of cognitive testing. So we'll ask you some questions. You work with blocks. There is also self-report questions. So this gets at kind of psychological functioning, personality functioning as well. So the testing can usually last anywhere around 90 minutes, I'd say, to about, 5 hours can be, if it's very extensive testing, I would say. So usually testing will last around 2 to 3 hours. And the testing is completed by either the neuropsychologist, or sometimes there's a technician that is well-trained in those measures and administers it. And then the neuropsychologist will then interpret those scores to write up a report. So usually that's all occurring on one day, as you will do the interview and the testing. And then you will go, as the client, you will leave, and the neuropsychologist will write up the report, combine all the data from the interview and the testing to give a diagnosis, and then really brainstorm about recommendations about how to help out with what the individual came in for testing, how in people with vestibular disorders, how to help out with that, thinking about like vestibular rehabilitation, therapy, anything that the research shows that supports treatment for that. The neuropsychologist will try to kind of brainstorm that and put it in the recommendation section.
Okay.
And then usually about a week to 2 weeks later, maybe even a month later, in my practice, it's usually about 2 weeks, the neuropsychologist will go over the results from the report with the client. What did the testing show? What are the diagnoses? And what, more importantly, what most clients are looking for is, what are we going to do going forward with this diagnosis and the information that we've gotten?
So we talked a little bit about what the evaluation might look like if a patient were to come in. So where do you see neuropsychology fitting into a treatment plan for a vestibular patient?
Sure. So I think one of the benefits of neuropsychology is that it's a place where we look at sort of the cognitive functioning, the emotional or psychological functioning, and just functioning in activities of daily living all in one place. And answering from the previous question, it's an unusual appointment because you are spending, 3 to 4 hours with the neuropsychologist in one day. So we're gathering a lot of data up. And so what's beneficial for a vestibular patient is we can get those readings in all those different areas. How are you doing cognitively? How are you doing emotionally? Are these difficulties affecting your everyday functioning? And then we can get this whole picture of you. And then that really helps with treatment planning going forward. So the neuropsychologist is big on planning the treatment. They're sort of the assessment person. And so getting a good reading of all those different aspects can really help the neuropsychologist and the client get together a treatment plan that focuses on helping those. If we have difficulties with cognition, if we have difficulties with psychological functioning, if we're having trouble with functions of daily living, we can look at recommendations and specific interventions that can focus in those areas and help the patient out. So if you maybe went to like a neurologist and they're very helpful, maybe the neurologist is only just going to look at the cognitive and some of the motor, maybe a little bit of the activities of daily living, but probably isn't going to do a lot of the psychological, emotional looking to assess systems. You go to just a psychologist, they're maybe not going to look at as much as the neurological and cognitive. They're going to look at maybe just the emotional and the functional living. But if you go to a neuropsychologist, they can combine all those different domains and take a look, and that can really get together the best treatment plan for you because it's addressing all of those domains that the client may have difficulties with.
That's a really great point. I love that because it can be really confusing as a vestibular patient. And I know this personally of what is driving this, is my anxiety a problem? Is it more of a problem than I thought? Do I have depression? Is it more the vestibular symptoms that are driving the brain fog that I might have, for example? So you make a really good point that we can get some objective data, which means comparing your scores to a group of people so we can kind of sort out where you fall on a continuum. So yeah, that's a really great point that I can really combine all of those things and really give you targeted treatment. So you're not wasting time trying to seek out all these things. You can really find out what is going to be the most helpful for me and how do I target that.
Absolutely. Because you talked about it, it's kind of a big piece of, why are we doing this testing anyway? And you talked about it as we're comparing you to other people to get an idea of where you stand with others. So the idea is that a lot of your cognitive functioning depends on your age and your education and demographic background. And so what we're doing with the testing is all of our tests have what's called a normative sample. So this is at bare minimum, usually a group, an age range of individuals that have completed the test. So if you are a vestibular patient that comes in, I look in those norms of these people that have completed the test. These people don't have a vestibular condition. They don't have dementia. They don't have ADHD. They don't have anxiety, depression, anything. They are people that have no disorders who've completed this testing, which is why they're the normative sample. They're individuals who are unaffected by anything that'll affect their cognitive scores. And we are comparing you to see, is your score comparable to that group of people? Is it an area of strength for you if you're doing better than people your age? Are you doing a little bit worse than people your age? And so that's when you talk about sort of a more objective, which is a strong word because testing in itself is affected by a lot of different things, but it can give you a general idea of where you're standing with other people. And that can give us some data points of, hey, yeah, maybe this attention is not doing as well compared to, say, other 40-year-olds that are coming in. That's a problem area for you. So I wanted to kind of go over that a little bit more because I think that's a part of kind of what is testing. Why do we even have to do testing? And that's the benefit of it, is that I can get of, hey, this is what you should look like for a 40-year-old. And this is what what I'm seeing here now.
Mm-hmm. Mm-hmm. So as a vestibular patient, I know like during a symptom flare or during a difficult time, it might be hard to want to go to an appointment like this. You know, you mentioned it's going to be multiple hours. So how might a neuropsychologist accommodate a vestibular patient to make the testing process more comfortable?
Sure. So I think that if you're having like a vestibular flare, we probably would not do testing. Because obviously if you are having vertigo or problems with balance and dizziness, you're probably going to be pretty distracted and that's going to affect all your scores. So I think it's one of the things to accommodate is trying to find a day that we're not having a vestibular flare, that we can have that testing done. Otherwise, I think I would talk to the client about what are possible triggers of kind of the dizziness that occurs. If it's lights or sounds, if we can try to find a quiet room that we're not moving around in. We need to turn the lights off as long as the client can still kind of work with the testing material and see well. That's things that can be helpful. But I think the big thing is just trying to find a day that we're not having one of those vestibular flares, because then we don't want that to kind of affect all of our testing, because it'll probably lower all the scores, attenuate all the scores, and then we're not going to get a good picture of what your functioning is. And I mean, the other side argument of that is that we do want to see what you look like when you have a flare, because that can really see what the testing, but we kind of already know that that's going to affect how you're paying attention to your environment. And what really neuropsychologists try to do is maybe try to get you in the best environment that you can function, I should say. And if you're still having problems, and when you're in an area where it's quiet, you're one-on-one with a person and you're still showing difficulties, then that's really identifying some problem areas that you may have.
Okay. So just to, I guess, pick your brain a little bit for the patient with chronic symptoms. So there are people, actually many people in this community, who would respond to what would be a good day for you by saying either my symptoms are really unpredictable or I have symptoms all the time. So is that something that the testing could still accommodate, or like, would you not recommend testing for that person?
So I would still recommend testing for that person. And we just need to, with the caveat that if we're dizzy all the time, that's likely going to lower all of our scores, because it's difficult to if you can't pay attention, that's going to affect all the scores. Because I mean, attention is required with all of the testing. I think the idea would be to still come in. And if we need to get a shorter battery, or we're just trying to assess the areas that we're concerned about, that might be whatever can be the least distressful for the patient, that the neuropsychologist can obtain the data that they need to make some decisions going forward. So it's not that if we can't do any neuropsych testing, if we're having a flare up all the time, if we're chronically dizzy, we may just look at it, still to get some good data, at least do an interview and see what we can get. But as a neuropsychologist, I don't want to put people in situations where they're distressed and things are getting worse. So the options, like I said, of shortening the battery and being flexible about it and getting the bare data that we need to help out with treatment planning.
I think that's a good point. And just, I'm not a neuropsychologist. I have some experience with it just from graduate school. I think another thing that comes to mind would be getting kind of a baseline assessment and then using that to compare it over time, maybe as the patient improves, which could be a really good comparison point.
Absolutely. So I mean, you're touching into things if for vestibular disorders, if we're going to do a surgery. And so let's get a baseline before the surgery and get an idea of all of this functioning, psychological, cognitive. Then we do the surgery, and maybe 6 months, a year after we recovered, you can get another testing point of that and see if anything is improved or if there's any lingering problems. If God forbid that surgery made some things worse, that can be a useful thing to do. And you can actually see maybe the benefit of the surgery or things that we still need to work on after that surgery.
Okay. So we talked a lot about testing and battery. And just one note here, in case patients are wondering, when we say testing, it could be like questionnaires, like was mentioned previously. It could also be things that kind of feel like school, like asking you questions that seem like math questions or identify pattern sort of questions. So when the neuropsychologist is looking through all this data, so someone's completed the testing, what patterns or what score patterns, I guess I would say, might you see with a vestibular patient? What does the literature or the research say are typical areas that a vestibular patient might struggle?
Absolutely. So I think one way to divide it up a little bit is the difference between, and I don't know if your learners are kind of familiar with like peripheral versus central.
Yeah, you can touch on
disorders.
You can touch on it a little bit if you don't mind.
Okay. So if it's more peripheral, if it's just kind of the inner ear and the vestibular nerve, then this is going to mostly just be kind of dizziness, problems with the gait, and obviously it's system dysfunction of just where your body is in space. And if it's accelerating or moving to the side, that's the symptoms that you're primarily going to be experiencing if it's just peripheral, the physical symptoms, I should say, of just peripheral vestibular dysfunction. Obviously on testing, what that's probably going to do is if you're dizzy, it's going to affect, like I said, your attention and your processing. So I'd expect that to be maybe a little bit lower, because if we're thinking about dizziness, we're dizzy all the time. That's distracting, very distracting. So you can attend to things as well as you would if you weren't dizzy or having vertigo symptoms. So that's probably going to lower all the scores, that are particularly things that are measuring attention. And something called executive functioning. And I can kind of get into that a little bit more if I want to dive in, because executive functioning is a big umbrella term. There's some research that shows that there is some visual spatial dysfunction, mostly with individuals, vestibular patients. So this is how we kind of deal with mental rotation of visual information, how we kind of think about visual information, and how well we are at kind of processing it in the brain.
So you mentioned spatial reasoning and mental rotation. So just for people to understand how that might fit into the real world, that might be things like rearranging furniture and being able to spatially see how that might fit. Merging into traffic might be more difficult. Packing a bag and kind of seeing how the items might fit together. So anyway, I just wanted to kind of make that a bit more maybe understandable for some people. So you were talking about peripheral. I didn't mean to interrupt. And then did you want to talk about central as well?
Yes, so central is, we talked about peripheral being maybe the semicircular canals in the ear and the vestibular nerve. But once it's the problem in the brain, because that information from the semicircular canals goes down the vestibular nerve, goes through the brainstem and into the cerebellum. And so when we have dysfunction in the cerebellum or areas of the brainstem, usually you'll have dizziness, obviously, because those are the parts, there's the cells that are processing that vestibular information, but those cells are also doing a lot of other stuff. So the cerebellum is an interesting part of your brain that is not researched very well. In fact, they're just, before probably a decade or two ago, mostly people thought that the cerebellum mostly just did motor coordination. So it's very involved in motor coordination. And that makes sense if you think about it, because the vestibular, your body's sort of image of where it is in space is your head tilted. All of that is very important with muscle movement and coordination. So that system's going into the cerebellum. Cerebellum is also getting at other information of kind of body sense, where your limbs are. So, I mean, if you close your eyes, your brain still knows that if I'm sitting right now, your brain still knows my knees are flexed, my arms are in this position. You don't suddenly feel like you're floating somewhere. So the fact that that system is existing, it's called proprioception, of where your body limbs are in space, is something that's not talked about. It's another sense. That information is coming in from the cerebellum as well. And it's coordinating with motor systems, I should say, not symptoms. So when we're having dysfunction in the cerebellum, we are going to have more problems than just kind of vertigo and dizziness. We're going to have problems with motor coordination and ataxia. And ataxia basically just means kind of motor coordination. And gait disturbance, you can be falling down. So you can have a lot more problems in the central vestibular dysfunction, because it's hitting areas of the brain that are really getting at more than just vestibular functions and integrating a lot of other information. And so when you see that on testing, neuropsychologists also do a lot of motor testing as well, and you will see those difficulties, not just the dizziness, but coordination. So like double alternating movements, that's difficult. If you do a neurological exam, which some neuropsychologists will do, you should leave it up to the neurologist to make the diagnosis, but some neuropsychologists will do the exam and you will see just problems with, they'll have like finger touching to the nose, and you'll see like problems overshooting. You'll have problems with speech. It's called dysarthria. So kind of slurred speech. There's a bunch of, so British Parliament, if I was trying to say British Parliament, it's not smooth. So the cerebellum is getting at this kind of smooth muscle flow throughout your body, coordinating bodily movements. And a part of that is getting that information from the vestibular system. And when the cerebellum is damaged, it can cause that dizziness, but then we're going to have all of these other difficulties as well, usually motor difficulties.
So you mentioned the difficulty with attention, which can impact memory as well, with visuospatial. So if someone were to come up with a pattern like this in testing, what types of recommendations might you make?
So I would recommend vestibular rehabilitation is probably something I would recommend. The other thing is that individuals who have obviously vestibular disorders, there's secondary issues emotionally, where usually that is causing some sort of anxiety and very likely panic. Because then the client's day is all about, if it is kind of what can I do with this dizziness, it's really impacting your functional living. And so people can't obviously go to their job. They can't enjoy their family. They are constantly dizzy. And so this is going to impact their psychological functioning. And they're going to have anxiety about, is this a day that I'm going to have a flare up? If it is something that's kind of coming and going, what am I going to be able to do today? And obviously that system's all tied into panic attacks and kind of you feeling out of sorts in any bodily sensation where you're kind of feeling out of sorts. It's more likely that you will have a panic attack and misinterpret that as something catastrophic. And that's a common thing. And then when we're having those functional impairments as well, it likely leads to depression. We are cut off more from people. We're not doing what we enjoy doing. And that can lead to depression. So talk a little bit about like vestibular rehabilitation, but there's a lot of usually psychological symptoms that are occurring that would benefit from psychotherapy, specifically psychotherapy that is focusing on, and there's models that will look at, it's very similar to maybe tweaked a little bit more, but like pain psychology, where we are having, obviously people who are having pain all the time, it's not the same, but similar to some of the problems that people with vestibular disorders are having. This thing is on them all the time. It's very stressful for them. And figuring out ways with therapy about how can I manage these symptoms that are occurring and still get to the goals that I want to do, live the life I want to live, and find that balance where some days we need to take a rest and some days we can push ourselves a little bit more, but trying to find that in between balance that we are still going and doing the things in our life that we want to do, and still kind of managing with the vestibular symptoms. So that's another kind of arm is, so I talked about vestibular rehabilitation, and I talked about probably psychotherapy for those emotional difficulties. If it's something that is, obviously this is more acute, but if it's more of a central problem, that can be a stroke or a tumor. So obviously that's probably being treated even before we go to neuropsychology. We have to think about that, because if we're having problems in the brain, there's significant, very likely even life-threatening issues that could be occurring. And so that treatment might already probably be going forward before neuropsych, but that's something to think about, especially for central vestibular dysfunction.
If someone were interested in pursuing this type of evaluation, what would be the best way to find a provider?
So the best way to find a provider is usually that individuals will go through their primary care physician. That's kind of the system, and the medical system is kind of like this wheel and spoke, hub and spoke, I should say, where the primary care physician is obviously organizing all of your medical information from all the specialists that they refer you to. So you could talk to your primary care physician will usually have a referral source for a neuropsychologist, just as they'll have a referral source for a neurologist or a cardiologist. It's very similar to that. And you can talk to your primary care physician about it, and then they'll usually refer you to a neuropsychologist in the area. You can also look at just your insurance company, because and maybe we'll talk about this later, many neuropsychologists accept people's insurance, and you can just be self-referred, where you can call up maybe a neuropsychologist and talk about it. And usually they'll try to include the primary care physician, because that's where the results are going to be sent, and where a lot of the treatment management going forward is going to come from, is that primary care physician. So we want to keep them involved, but you can kind of bypass it and self-refer yourself and look to a neuropsychologist in your area. Internet's obviously a great tool for that.
Mm-hmm. So you mentioned that many neuropsychologists do accept insurance. So is the full testing typically covered, or how does insurance fit into this sort of referral?
Yeah, so oftentimes insurance will cover most of it if you're reaching your deductible. We have from that it is necessary to do this, and the insurance company approves, they will cover the whole thing. Obviously, if we haven't run our deductible, there's going to be out of pocket for it, and you'll have to pay for some of it. And that depends on the neuropsychologist that you see, who's going to charge that. But it works very similar if it's insurance to all other insurances. If we have met our deductible, we have to pay that out of pocket. But once we hit that deductible, the insurance will cover all of it. And then obviously there's some situations where fortunately insurance won't pay. We have to pay out of pocket to complete that testing.
So I just wanted to thank Dr. LaTulip so much for being here. This was a really interesting interview. And if you're interested in pursuing a neurological or a neuropsychological evaluation, I'm a big fan. I think it's really helpful in a really interesting area that many people are not pursuing, probably because maybe they haven't heard of it. Mm-hmm. So thank you for being here. Again,
Absolutely.
I'm Dr. Kostelnik. You can find me at rootedbehavioraleducation.com. Or on Instagram or Facebook, and we'll see you next time.